Hello and welcome everyone to this American Interventional Headache Society webinars. Today we'll be discussing cervicogenic headaches and cervical radiofrequency ablation procedures. I'm Dmitry Souza. I'd like to thank you all for joining us today, but in a wider sense, for your dedication to what you do and dedication to your patients. I'd like to thank American Interventional Headache Society and American Board of Headache Medicine for this unique opportunity to learn from the best. And just for you to know, the speakers graciously donated their time and expertise to educate us. I'd like to thank our sponsors for today's program, Medtronic and Boston Scientific, for their support of this program, this webinar, so it can be free for you. These companies produce equipment for the RFA, but also, I think more importantly, they've got amazing, nice, and knowledgeable representatives. Their hard work all too often get unnoticed. Specifically, I'd like to thank Amy Moore from Medtronic, Patrick Malone, and Tricia Howell from Boston Scientific for their dedication, their hard work. And of course, thanks to our speaker, Dr. Lynn Cohen from University of Virginia. She serves as the Director of Pain Fellowship and Associate Professor of Anesthesiology and Pain Medicine. Lynn is well known in pain medicine world. She is well published. She holds leadership positions at national societies. She's a great teacher. And Lynn, we are lucky to have you today as a speaker. One more note before we start, please be at lookout for further webinars and boot camps and workshops, as these activities, they count towards the headache board certification. Also, please type your questions in the Q&A box. We'll discuss them and at the end of the presentation. Please welcome virtually Lynn Cohen.
Thank you so much. Thank you very much for the invitation. It's much a pleasure. And so tonight we are going to talk about cervical RFA, some new advances in terms of the technology and how that is applied to the techniques that we use to perform cervical RFA. And again, thank you to our sponsors. So we'll first kind of just an outline, we'll kind of talk about the conditions that we use to treat with cervical RFA, so cervicogenic headache and neck pain. We'll talk about some basic anatomy, indications for the procedures, technique, efficacy, and complications. So cervicogenic headache is one of the things that we can use cervical RFA for. It was first introduced in 1983 in Norway. It was described as head pain that was referred from any bony structures or soft tissues in the neck. Initially, it was just defined as a unilateral headache that varied in intensity, but was typically non-throbbing. But it was made worse with certain movements of the head and the pressure over the tender areas in the neck. It was pain that originated in the neck and it radiated to the occiput, frontal, or temporal regions. It affects about 0.4 to 4% of the general population, but this is higher in patients that are actually presenting with headache. But it may be as high as 53% in patients with headache after a whiplash type injury at some point. 4 times as common in women, and the mean age is around 43 years old. So it has a very significant impact on the quality of life for patients. So patients with cervicogenic headache report higher scores of bodily pain than other patients, than patients with other types of headache, and higher limits of physical function than patients with other types of headaches. So it can be very disabling. So a subsequent, in 2013, the International Headache Society came out with the specific criteria for diagnosing cervicogenic headache, and which are as follows. So any headache that fulfills criteria C, which we'll talk about in a moment. And then you have to have some kind of objective evidence, so clinical, laboratory, or imaging evidence of some kind of a disorder or lesion within the cervical spine or soft tissues of the neck that is kind of known to be a cause of headache. And then C, kind of the main part, is that you have to have causation demonstrated by at least 2 of the following. So the headache had to have developed in a temporal relation. So timing-wise, it has to make sense in terms of the onset of the objective finding. So that's cervical disorder or the appearance of the lesion. Or the opposite, the headache actually improved or resolved in time with the improvement or the resolution of the cervical disorder or the lesion. Number 3, it has to be cervical range of motion is reduced and the headache is made worse by provocative maneuvers. And then number 4, it says the headache is abolished following a diagnostic block of a cervical structure or its nerve supply. And that word abolished is in their criteria, however, that is clinically somewhat controversial because as we know, patients can have different reasons to have pain and there could be overlap, and sometimes it's hard to completely abolish a pain source just from a nerve block. And then finally, it cannot be accounted for by another ICDH diagnosis. But it's also important to keep in mind that that the symptoms are not distinct, that there can be overlap between different types of headaches. And so it is important to kind of try to figure out, is there overlap or distinguishing features that might help to distinguish it from other types of headache disorders. And so the etiology, why do these develop? And so any of the structures that are innervated by the upper 3 cervical nerves or the trigeminal nerve can contribute to cervicogenic headache. And an important factor is that there's actually the trigeminal cervical nucleus. So any of the structures that are innervated by those 3 upper cervical nerves or the trigeminal nerve, they converge onto the second order neurons within this trigeminal cervical nucleus that then can cause this kind of transfer of pain, this bidirectional transfer of pain from any of the structures essentially within the face or the neck or the head. And so people can kind of get referred pain from these areas, which can complicate sometimes in terms of diagnosis, but it's important to realize that there's this relay between these areas. And so even though patients might have kind of pain in the neck, it also can feel kind of referred pain in the face or vice versa. So what are the structures that are innervated by these nerves? And so they're listed here, and some of them are definitely important when you're talking about cervicogenic headache, but such as the atlanto-occipital joint or the AA joint. However, for the purpose of this lecture that we're going to be focused on cervical RFA, we're mainly going to focus on some of the facet joints. But it is important to realize that all these structures can potentially contribute. And so how do you make the diagnosis? So of course, you always want to do a thorough history. You always want to look at your review systems and a neuro exam because you want to rule out red flags or other evidence of systemic disease. Imaging can also be ruled out, can be used to rule out other contributing factors, but it's important to realize that imaging in and of itself does not make the diagnosis, nor can you confirm the diagnosis by physical exam. So the only way to really confirm the diagnosis is to do the anesthetic block of any of the structures that could be contributing to cervicogenic headache. And we had mentioned some of them in that differential. And so again, it can be from the AO joint or the AA joint. And there's certain, pain patterns that may lend you to think that it's coming from those areas. We're going to focus again more on that kind of C2, 3 joint and some of the lower joints when we're talking about neck pain. And so in terms of the diagnosis, you would want to kind of rule out these other things, potentially rule out lower cervical facet syndrome. If a patient has pain and kind of this type of a pattern in the back of their occiput, or potentially just kind of pain over that C3 joint, and particularly if they potentially have had a history of whiplash injury, a car accident, then you might start to think that it's more the cervicogenic headache coming from the third occipital nerve. So you'd want to block the third occipital nerve, and then if they get good relief, and we'll talk more about percentage relief and blocks later on in the talk, but then you might consider the cervical RFA. And again, these are the other structures that can be contributing to cervicogenic headache, so we're going to be focusing more on those facet joints. And so, and aside from cervicogenic headache, cervical RFA can also be used to treat neck pain. So neck pain does have a high lifetime prevalence of really 40 to 70%. So a lot of patients at some point in their lives may have neck pain. The prevalence is about 40 to 55% in patients with neck pain based on medial branch blocks. The etiology, often the cervical spondylosis, which is known to increase with age. only about 13% of men over the age 20 have cervical spondylosis, but almost 100% of people over the age of 70 have some type of cervical spondylosis. Again, this is important because you can't just take an X-ray and say that they have cervical spondylosis and that's the cause of the pain, which we'll talk about it in a little bit as well. But it's also common after previous whiplash injury. And so cervical facet syndrome, typically patients may complain of a deep aching sensation in the neck, potentially with sharp shooting sensations that are aggravated with movement. They kind of always have this deep aching. They might have some sharp sensations as well, particularly when they're moving. Typically kind of non-dermatomal. In the physical exam, this can be tenderness to palpation or spasm. Often the overlying muscles can be aggravated as well. You tend to not see neurological deficits. And then there's the decreased range of motion. And so you also always want to think about red flags. And so red flags, they can be in terms of many causes, but, systemic signs, these type of neurological findings is that, you might want to investigate for further causes or, age over 50 with a history of cancer. These are things that you need to investigate further and not just assume that this is neck pain from cervical spondylosis or cervical facet syndrome. And so the cervical spine anatomy is a 5-joint structure. And so you have our paired facet joints that are covered with articular cartilage, and they're surrounded by a fibrous capsule that is lined with synovium. And so you have your inferior and your superior, and together those make the facet joint. We also have the uncovertebral joints that are paired as well, which you can see here, and then the cervical disc. And as we know, the cervical disc is poorly vascular, so it can be difficult to heal. And only the outer to 1/3 of the annulus fibrous in the healthy disc. And there's poor healing and gradual progression of disease after insult occurs. So what about the facet joint itself? And so the facet joint, why does it hurt? And so facet joints contain free and encapsulated nerve endings. And so the nerves in the facet joint contain things like substance P or CGRP, and kind of these inflammatory mediators. They also contain low threshold mechanoreceptors, mechanically sensitive nociceptors, and silent nociceptors. So all these things may respond to noxious stimulation, and so including moderate to severe levels of osteoarthritis, which results in them, essentially being this nociceptive stimulation that's perceived as headache or neck pain. And the reason what they did to kind of find out some of these patterns of pain is they took normal volunteers and they essentially injected saline into the joint and kind of reproduced what the patterns of pain became. And so that's how we get these painful the pain diagrams in terms of the relation to where the pain is and which joints are potentially effective. So it's not perfect because these were normal, healthy volunteers, and so we don't know exactly, but it does give you kind of a rough estimate of which joints potentially you should be targeting. I often show this to patients and kind of let them pick out their painful area to kind of guide us into deciding which joints to potentially select to treat. And so the facet joints are supplied by the medial branch nerves. And the medial branch nerves are right off the corresponding cervical dorsi rami. And so they come off, numerically the same level of the vertebral body. So they assume a curved course. And so in your AP, you're going to see this kind of wrapping around the waist of the articular pillars. And then in the lateral, it's going to run transversely across the articular pillar. So you're going to see kind of coming in the middle. We're going to talk more about this later in terms of kind of the where they run. But the medial branches are bound by fascia and they're held against the pillars, essentially by tendinous strips of the origins of the semispinalis capitis. And each facet joint is supplied by a medial branch nerve above and below the joint. And so the C2-3 joint is a little bit different from the others, but it is the most common cause of cervicogenic headache. Patients can present with that tenderness over the joint, and it's supplied by the third occipital nerve. You can see here the inferior and the superior articular processes in the joint. And so the third occipital nerve is one of the medial branches of the posterior ramus of the third cervical nerve. It's important because it actually has the third The posterior ramus, the third cervical nerve, actually has two medial branches: superficial branch, which is the third occipital nerve, and the deep branch, which essentially is just a C3 medial branch nerve. It winds around the C2-3 facet joint as it heads towards the spinous process, and then essentially pierces the overlying muscles and reaches the scalp. And it supplies motor to semispinalis capitis. And again, it kind of gives that sensory to that superior nuchal line and up to kind of that C2-3 facet joint line. So again, here we talked about how there's the two branches of that dorsal ramus. So you have the C3, the superficial branch, which is the third occipital nerve, and then the deep branch, which is the C3 medial branch nerve. And the anatomy of this nerve, the third occipital nerve, is different than the other medial branches. It's larger in diameter, and that'll be important in terms of some of the techniques when it comes to lesioning that nerve. Which you can see here in the picture, it's a larger nerve than your other medial branch nerves. And you can look at the diameter, it's larger than the other nerves. And so you just, in terms of the size and somewhat of its variable position, can mean you might have to make more lesions in some techniques. And then the lower cervical facet joint, the C3 through C7 joints, kind of be depicted here. Again, your joint line, and in your lateral, these are your joints, but these are the articular pillars where the nerves will run. And so just a chart of showing again that each of the nerves comes off the posterior cervical ramus of that nerve. So the C3 medial branch derives from the posterior ramus of the third cervical nerve, and such forth. They have the posterior cutaneous branch. They essentially wind around the articular pillar of the corresponding vertebral body, pretty much all terminating within the multifidus muscle, which is important when we do motor stimulation. And then you can see they each have slightly different motor and sensory supply. And so cervical RFA. So what exactly is it? And so essentially, there's high frequency electrical current to produce controlled thermocoagulation. It's essentially thought to produce Wallerian degeneration to the afferent nerve fibers, denaturing the A delta and the C fibers, thus preventing signal conduction. And so when do you do cervical RFA? So head or neck pain that's persisting for more than 3 months, that's not been responsive to conservative therapy. And so patients might have tried physical therapy first or did not respond, or conservative medications, NSAIDs, potentially amitriptyline or TCAs, and things of this nature. And then in your performance of a diagnostic or prognostic blocks. And the percent of relief from these blocks is controversial in terms of how much percent is needed to move on to RFA, or how many blocks you need, and we'll talk about that later. So the commonly used equipment, there's different companies that have radiofrequency generators with, each a little bit different. And so there's also different types. So there's cooled RF, and there's what's called these, the venom type protruding electrodes, needles. And we're going to talk about why all this is important in terms of the technique that we choose. But the RF needles also vary in size, their gauge, and their needle tip. You can have curved needles, you can have straight needles, you can have different, as I said, gauges of the needles, different size active tips. And these are important in terms of the creation of your lesion size. And so in terms of the different techniques, we have our traditional, which is just continuous, and the tips essentially heats, the 80 degrees Celsius. We have cooled, which is also continuous. It's still a thermal, and despite the fact that the tip is 60 degrees, the surrounding tissue is thought to still heat up to that 80 degree threshold. We have protruding electrodes, where this is your venom type needle, where it splits into at the end, which is also a continuous technique, again, kind of heating to that 80 degree threshold. And then we also have pulsed. Pulsed is different, it's not continuous. It gives quick 20 millisecond bursts of energy, twice per second, followed by a quiet phase. And this goes to 45 degrees Celsius. And so it's different than the other three techniques. And in terms of whether or not it truly creates a lesion. It traditionally had not been thought to create a lesion, but potentially more kind of creating this electrical field to kind of alter potentially C-FOS and C-June and pain transmission that way. There's a little more controversy now about whether it maybe does cause a little bit of some kind of denaturing to create a lesion. But the important part is in terms of the differences and where the energy comes out with some of these techniques. And so for the continuous techniques, and we'll kind of come back to the cold in terms of what I'm about to say in a moment, but comes out surrounding the needle versus out the tip of the needle. This will be important in the technique you choose to perform your cervical RFA, because you need to decide whether you're going to come perpendicular or parallel to the nerve. And so for the most of the continuous techniques, and again, with the exception of cold, which we'll talk about why in the next slide, you're going to need to place the tip parallel to the needle, because that's where your heating is going to be the strongest. For pulsed, the electrical field is actually strongest at the tip of the needle. So it's going to be protruding out the tip where you're going to get that strongest electrical field. And so again, this plays into the decisions of which technique you're going to use. And so when we look at the different lesions that are created, again, when you have kind of the traditional thermal continuous lesioning, you're going to get most of the lesion surrounding your active tip with not much protrusion off the tip. And this is true even for the protruding electrode. Same again for your monopolar, your traditional thermal needle. You're going to get most of your lesions surrounding the tip versus out the top of the tip, as opposed to cold. So cold is different, and because it essentially, and you know, a lot of people with the misnomer cold, even insurance companies, I think in the beginning, were were resistant because they didn't think it was actually a thermal lesion. This is a thermal lesion. However, the cold water is being used to dissipate the heat to allow the lesion to propagate. And so you're going to get projection off the distal tip. And so for this reason, you can potentially, you can come perpendicular to the nerve and still get a lesion. The protruding electrode does allow for potentially creation of a larger lesion size surrounding the tip, because it has that protrusion. But interestingly, compared to a monopolar 16 gauge, made a slightly bigger lesion than an 18 gauge protruding. But if you're looking at the same gauge, 18 versus 18, you're going to get a larger lesion surrounding your needle tip with using a protruding electrode. Again, these are just kind of some of the pictures in the skin. So this is your protruding electrode. This is the protruding electrode over time. Over time compared to your cooled RF electrode. So again, you can see more coming at the tip. But here you're going to get a lesion that's going to be surrounding the tip, surrounding your active tip. And here again, a cooled RF lesion compared to a monopolar lesion. So monopolar thermal lesion, very little distal propagation of the lesion. And so this is important in terms of choosing your technique, but the choice of technique can also be decided somewhat based on body habitus and also just what you're most comfortable doing. Some of the techniques are easier to perform than the others. And so we have a lateral technique, which the patient can be supine or lateral, and we'll talk about this. It's coaxial. It tends to be probably the easiest to perform. Posterior technique, which the patient will be prone, and this allows the needle to be placed parallel to the medial branch nerve. And then a posterior lateral technique, which is essentially performed in an oblique view. Unless the patient can be supine, and so it could be easier for the patient in terms of comfort, in terms of laying. You can maintain eye contact with the patient, but it's a little bit more of a learning curve. And so here you can see too, just the different ways. So lateral, where you're coming straight in, posterior, where you're coming posteriorly from behind, and the posterior lateral technique, where you're coming in obliquely. And so the lateral technique was initially first described for medial branch blocks, because for medial branch blocks, you can come perpendicular and just deposit your medicine. But it was later described for medial branch denervation. particularly now with cool leaf, because you can come perpendicular because you get that distal projection of your lesion. The patient can be placed supine or lateral, and the x-ray is positioned so essentially there's a coaxial view. So if the patient's supine, you move your C-arm lateral to get a lateral projection, but if the patient's lateral, the C-arm itself is AP, but you're getting a lateral view since the patient is lateral. And the target is the midpoint of the rhomboid-shaped silhouette of the facet columns. And so what does this mean? One of the most important things of the lateral technique is that you have to align your articular pillars. And so if your articular pillars are off, this can be dangerous because you need to be able to hit bone. You need to know which side of the bone you're hitting. There can be a risk of spinal cord injury if your articular pillars are not aligned properly. As you can see here, so a lot of times you have to adjust your C-arm, both medial, lateral, potentially wigwag, or cranial caudal to align them. You might have to do that for different levels because you can see at the lower level, these are aligned, but here they are not. So very important to align your articular pillars. And so again, we talked about the target being that midpoint of that rhombus. And so here's the midpoint. If you're going to go down to T7, then it's a little bit higher up, but for most of the medial branches, you're going to aim for the target in the middle. And so you essentially can just put the marker over that area on the skin. You can advance straight down, kind of the down the barrel technique, straight onto bone. You can repeat this for each level. Sometimes it can be difficult in terms of some of the lower facets if patients have large shoulders, and that can be one of the disadvantages to this technique. In terms of positioning, if you are positioning them lateral, you're in the lateral decay position, and you want to put some kind of a pillow, or usually kind of a square foam pillow works well under the head to try to get it in proper alignment. So again, you want to basically square off your articular pillars and just come straight down to that middle of the target there. You can see here in the video, coming straight in and just hitting down to the target of the bone. You can see then if you were to go to your AP view, you can see that waist where the medial branch goes within the articular pillar. So posterior technique. Probably the most common technique that is used, especially with the traditional lesioning. We talked about you have to be perpendicular, you have to be parallel to your medial branch nerve in order to get an effective lesion. So this was first published in 1996. In the X-ray, you're often using two views, so typically AP and lateral views. So the patient is prone, and so this sometimes can be difficult for some patients to kind of lay prone, but you want to prop up their chest so that way their head can kind of be flexed with a little bit of a pillow or something for the head, the forehead to rest on. It could do potentially slight caudal tilt of the C-arm to properly align the facets, sometimes even maybe a little bit of an ipsilateral oblique to try to identify the waist of the articular pillars better. And so usually you start in the AP view and you identify the vertebral bodies that you're going to be targeting. Sometimes it can be difficult also sometimes in this technique with the face and the jaw kind of overlapping the upper cervical facet. Sometimes you have to try potentially having a mouth open or mouth closed, but sometimes that can be challenging. And we'll talk about what to do in that situation in a moment. Often it's easy to identify T1 because of the large transverse process. You could also try counting up. And so what you want to do is you want to mark the skin overlying by identifying the waist. Mark there. I sometimes say to go just slightly lateral to that because then you can kind of come and walk in towards the bony process where the nerve lies. To advance along the waist of the articular pillar, so you need to go to your lateral view for depth. And often you could also sometimes go to your lateral view early if you're having trouble in terms of seeing the anatomy because of potentially the jaw being in the way, to see if you're coming in targeting the proper level. So you can kind of go, you could go lateral even when you're fairly superficial to kind of just double check your vertebral bodies are correct. And essentially then you want to advance your depth in this view until you're at that target or the midpoint of the articular process and the midpoint of the rhomboid. You want to always then go back to your AP view to check to make sure you're still hugging the waist and that you're not too far lateral. And so again, this is a CT rendition of the facets, the articular pillars, and you want to essentially think about it as being, if you took a diagonal line connecting all the ends, kind of that midpoint is the intersection. That's the midpoint. You can see here, this is the RF needle tip probe coming in, again, at that midpoint line. And again, then rechecking in your AP to make sure you're hugging the waist and you're not too far out laterally. And again, here, same thing, trying to find those waists, and then starting at the waist, but then coming to your lateral to see your depth. And you can see here in the video, you're going to be targeting that place there, and then you can go to your lateral to advance to find that centroid of the rhombus. And making sure that you're laying against the bone to get that active tip parallel to the nerve. And then the posterior lateral technique. And this is probably the technique that's the least used. It was first published actually in 1980, so it was actually the first to be published. When the C-arm is actually in the oblique position, so you're actually visualizing the neuroforamen. And the target point is at the caudal aspect of the neuroforamen posterior to the neuroforaminal line. Or another way of thinking about it is you can look for the tips, the peaks of superior articular processes on the anterior part, and sorry, the cursor keeps disappearing, and essentially draw a line between those things. And the medial branch nerve will be at the midpoint of that line. And so the needle insertion, so the target in the skin would just be posterior and caudal to the target, because you're going to want to angle the needle as you're advancing kind of in an anterior and cranial angle until bony contact is achieved. The angulation is important to try to just get that perpendicular kind of position of the needle. But it's also in terms of the technique, as you get deeper in, it sometimes can be harder to adjust the needle. If you're too anterior, you need to be careful because you don't want to end up in the foramen. But if you're too posterior, you can actually go between the lamina and enter the epidural space. And that's why this one is probably the most technically challenging of the procedures techniques to perform. But you want to oblique your C-arm 20 to 30 degrees. And kind of, again, we talked about that, kind of finding the posterior line of the foramen, but the tips of those superior articular processes, and kind of that midway point. When you go to your AP, because you still want to check to make sure you're near the bone, again, you're still going to be at those waist of those arterial processes. You might have to angulate the C-arm about 10 to 20 degrees caudad just to get some nice alignment. You can see here, so kind of that oblique view and just coming in to target that midpoint of that line between those peaks of those superior articular processes. The nice, advantage of this is that those patients who do have broad shoulders, especially for those, if you're targeting the lower facet joints, you might be able to get a better view than if you're using the posterior or the lateral technique. And so those are for some of the lower, so C3 to C7 facets. The technique for the third occipital nerve, similar, but there's just important things to note, is that the nerve can be variable. We also talked about how the nerve was big. And so some studies or techniques advocate for using several burns. So the most common course of the nerve, is typically across the nerve, but the nerve can be located high, the nerve can be located a little bit low. So by using multiple needle technique, you're potentially increasing your chances of capturing the nerve and not missing it. Instead of going around the waist of the articular process, the third occipital nerve comes right across, like we talked about in these pictures, essentially the C2, C3 facet joint. But again, it can be variable. So in that lateral view, it could be a little bit high, it could be right across, it could be a little bit low. And so again, kind of just showing this 3-needle technique. But not everyone has to do a 3-needle technique. And so posterior technique Again, you can come at that instead of the waist, you want to come at that C2-3 facet joint line, and then your lateral view advance across that joint line. Posterior technique again. So here showing the needle coming towards that C2-3 joint line, and you can do C2. Contrast can be used, and we'll talk about why contrast can be used and when we get towards complications. But you want to come in and kind of go across that joint line. Posterior lateral technique, just like we talked about before, you're going to go in the oblique view, but again, still targeting that C2-3 facet line, and again, still hugging that waist or the joint, the C2-3 joint, but hugging near the bone and not being too far out laterally. Again, here showing that joint line. And then the lateral technique, you can kind of pretty much just come straight down towards that C2-3 facet joint line. And so once you've placed your needles and before you're going to actually do your burn, you just want to take a look at certain things. So you always want to look at your impedance. The impedance, essentially talks about the proximity of the electrode to certain things. And so if you're in CSF, which hopefully you would not be, but you would have very low impedance, or a blood vessel. So in a blood vessel, your impedance might kind of vary because as the blood flows. If you're bone or there's a lot of scar tissue, you can have high impedance. And if sudden large increase, you need to be careful that it went from some kind of fluid to a tissue. So impedance typically can be between 200 and 800. And so just something to think about. Testing. So do you test before you do your burn? And so this is, controversial. So there's definitely different schools of thought in terms of do you need or do you not need testing? So sensory testing is at 50 hertz, and patients essentially might report pain, tingling, just something different between 0.1 and 0.5 hertz volts, ideally. But there's some reports essentially say that you can potentially optimize it for that patient. For patients with diabetes or neuropathy who might not have a strong sensory feelings, to optimize that for that patient. And some of the lumbar facet medial branch research says that there's low quality evidence to suggest that sensory testing is indeed helpful. And so it is varied in terms of what people are doing in terms of sensory testing. Motor testing is 2 hertz and no less than 2.5 to 3 times the sensory stimulation threshold. Motor stim can be useful to make sure you're not too close to that ventral nerve root. And lesion time. So lesion times vary. Traditionally, probably, for 80 degrees, 60 to 90 seconds, maybe up to 120 seconds. And for cold, it's typically performed at that 60 degrees for 150 seconds. So common side effects and complications. So when you're denervating the third occipital nerve, patients can report numbness, dysesthesia, hypersensitivity, itching. They can report temporary ataxia. And one of the studies reported that to be about 95%. I'd say clinically you don't tend to see that, but it does go away. Injury to the vertebral artery or nerve roots, and we'll talk about that in a moment. And a very rare chance of some kind of spinal cord injury. Again, if you're doing that lateral technique, you need to make sure your articular pillars are aligned properly to decrease this risk. For some of the lower facets, you still get numbness in the cutaneous territory of the nerves, with the medial branches, the skin that they supply. Dysesthesias in the same area. Some patients will report like a sunburn type feeling temporarily. Post-procedural pain, patients can vasovagal. There's low incidence of neuritis. Some people will automatically use a steroid to prevent neuritis. We do not use that in our practice, and we almost have no reports of neuritis. But when we talked about injury to the vertebral artery, and so I think that slide is important, particularly when you're performing, that third occipital nerve denervation. So what this is showing is a vertebral artery, but there's loops. And so a large percentage or a fair number of percentage of the population may have a loop of their vertebral artery. And why this is important is that you're coming pretty close to those areas that you're targeting when you're doing third occipital nerve blocks or third occipital nerve denervation. And so this is depicting potentially the typical areas you may go for a block, and you see it's fairly close. It becomes even more important when we're talking about denervation, because denervation, you may be more anterior. And so what these lines are showing is if you're doing the oblique, the posterior lateral approach versus the posterior approach. And these are depicting potentially the needles, but this is where the needle depth would be for your oblique versus your posterior approach. And essentially what this is showing is that these fall in these E and D ranges in this grid. And so they found that on the left-hand side, about 4 to 8% of patients may have a loop in that area in terms of the vertebra already loops into that area. And on the right side, it's just higher. It's about 40% of patients might have a loop into that area. And so while this is a safe procedure, it's something I think that's often overlooked, especially if you're going to be doing that oblique approach, because your needle is going to be more anterior. That, you know, they're saying in this, which is in this D range, that up to 50% of patients might have a loop of the vertebral artery in that area. And you can see, you know, if you use contrast, you can see using DSA if you have it, or then if you don't, I would advise using live fluoroscopy. Just you can see the vascular loop. So it's just something to think about. Other common side effects. So one thing I think that sometimes gets asked is, you know, is arthropathy a complication? It's really not been found to have to be a complication, and so there's not really you don't need to really worry about that. And what about efficacy? So does it actually work? So there were some earlier studies that showed efficacy, but you know, some of these were observational. So this study, one of the earliest studies in 1996 by Lord, was a double-blind randomized trial. There was only 24 patients, and the median time to return of 50% of preoperative pain was 263 days. The patients did get fairly long-lasting relief for a long time. And these observational studies, it was up to 422 days. And again, in another observational study with a larger amount of patients, again, almost, you know, getting close to a year's worth of relief. And so some of the newer studies, so this is 2016, this is a systematic review by Engel, essentially looked at 8 papers that met qualifications. And essentially most of the studies reported almost complete pain relief at 6 months and at least a third of the patients up to 1 year. We found that the number needed to treat for complete pain relief at 6 months was 2. Which, as many of you may know, this is actually really pretty good for pain because a lot of the medications we use do not, you know, you need 5 or 7 in terms of your NNT. And so it can be showing that this is a good and potentially effective procedure. Patients also return to work and other activities, so they improve their quality of life. They were able to do things. So overall, they suggested that cervical RFA's effectiveness. They looked at the quality of the evidence. They graded the effectiveness as high quality. We found that there was low risk of complications, but and that was generally well tolerated, but the quality of evidence on that was low according to the grade guidelines. So what about the duration of response in terms of even with repeat procedures? And so this was actually using a 3-needle technique for the third occipital nerve and for cervicogenic headache. We found that 88% of patients achieved a successful outcome, which was reduction of the pain. And the duration was 297 days, and 8 patients had even longer than that. But then when the pain came back, they actually repeated it. So 14 patients had the procedure repeated, and 12 of those 14 patients, so 86% had successful outcome with repeat neurotomy. The duration, again, so 217 days. So it's showing that even repeat procedures, you can still get a long duration of pain reduction. There are no real side effects that required intervention, and the side effects that patients did have were generally well tolerated, especially in change for the relief of the headache. So why do they fail? So sometimes, diagnosis, we talked earlier about that, 100% in terms of qualifying as abolishing pain for make the diagnosis, but we know patients have coexisting conditions. And so, they might get some relief, but it might also just be that all their other pain generators are acting in, and so they don't get the relief that we expect. You have false positive or placebo responses. And can this be minimized by more stringent selection criteria? We'll talk about that, I think, on the next slide. Patients can have anatomical variations in terms of their nerves. You might miss the nerve, so that's technical failure. Inadequate treatment, you didn't actually burn the nerve that was desired. So what about percent relief? And so some of the studies essentially are showing that percent relief from a single medial breech branch block, whether you use 50% or 80% criteria, essentially resulted in the same success rate. And then they looked at either single medial branch blocks with the 50% relief or 80% relief with dual. And so this one's showing if you use a little bit more stringent criteria, you may get more success. The general thought is that it's generally a safe procedure, and by using too stringent criteria, you might miss patients. Volume. So using smaller volume will increase your specificity compared to using a larger volume. And this I definitely, do recommend, because you do want to target the medial branch nerves and not want your medication to be spilling to adjacent structures. And again, 1 versus 2 blocks. So 2 blocks associated with significant false negative rates. So, you might be missing people if you use too stringent of criteria. There was also a recent study that looked at essentially, it was a retrospective study. They called patients via phone survey, follow-up time, 6 months, 12 months, 2 years later, to see how they were doing. And basically, they were comparing patients who had had medial branch blocks, which they needed 80 to 99% relief versus patients who needed 100% relief. They found that overall, the percent relief after their medial branch denervation was the same, about 54%. So it didn't matter if you used the 80% or the 100% cutoff as your threshold, the outcome was the same. And the good thing is that they found that that 54% of patients overall did get relief of pain by more than 50%. Close to 80% had pain relief by greater or equal to 2 points. And 2 points sounds low, but in pain research, this is kind of generally a number that's often correlated with clinical improvement. And then they also looked at global impression of change, and patients who essentially did report that they were satisfied. So again, not only the important point that it didn't necessarily make a difference, the 80 versus 100, but overall people, did better with the procedure, and they felt they reported that they were better. So in summary, it can be a very effective procedure for cervicogenic headache or cervical spondylosis syndrome. Complete relief is actually possible in some patients and may persist for some time. Repeat procedures can offer similar efficacy and duration of relief. It's a safe procedure generally with minimal side effects, but beware of anatomical variations. As we saw, you can, problems in terms of, especially at some of those higher, the C2-3 with vertebral artery. Pulsed RF may offer similar efficacy with fewer side effects, but there's less support than conventional, so traditional or cold RF. And technique use may vary, may depend on the body, how it is, and technology used. So just make sure that you know the physics of the devices that you're using and understand how those may relate to the technique that you use, whether or not you can come laterally or whether or not you have to be parallel to the nerve. Thank you again to our sponsors, and thank you again to AIHS, and thank you to all the attendees.
That was a fascinating talk. Thank you so much. It's virtual applause, and we're ready to proceed with the Q&A part of our session. Before that, I'd like to thank you all again for sticking with us. And this is, it's actually a lot of people joined during the talk. please look for the the recording and the presentation itself on the website. It's a lot of information. It's in-depth analysis, but so concise. That's very impressive. Thank you. We'll start with the first question. Does anyone ask for SPECT CT to identify inflamed joint?
And so, we do not ask for SPECT CT. When you look at, the recent the lumbar international lumbar guidelines that just came out, of all the imaging modalities used, SPECT probably had the most correlation. But again, this is not clear. It's not strong evidence at this point. So I don't think most people are asking for SPECT to identify an inflamed joint. There was not necessary in all the studies a specific correlation to an inflamed joint and outcomes.
Mm-hmm. Thank you. I would also add that you can clinically suspect an inflamed joint, not necessarily doing a nuclear study. If somebody had an injury, recent whiplash injury, or some like similar conditions, the treatment may be different from neuropathic pain. For example, you may consider using some steroids, and maybe even if you look for approval of regenerative medicine options there. Next question. During cervical RFA, should you observe localized neck muscle contractions during motor stimulation?
So the medial branch nerves, supply that multifidus. So yes, you should. You definitely want to make sure you're not seeing contraction, of any down the arm or into the hand. There is one study, I forget who it's by, but actually showed that potentially multifidus stimulation might actually be more accurate than sensory stimulation in terms of, identifying that you're close to the nerve, the targeted nerve.
Mm-hmm. Excellent. Thank you. Next question. How many levels are considered safe to do RFA in one session? Is it recommended to do nerve block before doing radiofrequency? There are two separate questions.
So, I don't know if I saw any studies in terms of how many levels are generally considered to be safe. I think the most we typically tend to do are 4 levels. Some people might do bilateral. So then you might be doing more levels if you're doing that bilaterally. I think sometimes it was also getting away potentially from safety, but from insurance standpoint, in terms of multiple levels, if in terms of some of that posterior technique, which sometimes in the posterior technique people will do like multiple burns at each level. So if you're doing multiple burns at each level and then multiple levels, I think you might need to be more careful, because then you might get a little bit of a head heaviness or muscle weakness from that. Mm-hmm. But in terms of a specific number that's safe to do or not to do above that, I'm not aware of anything that says like this is a specific number you should never do above.
Okay.
I would recommend to do nerve block before radiofrequency. So again, this is controversial. There's there was a Cohen study on lumbar radiofrequency that showed actually from like a cost-effective standpoint, it actually made the most sense just to go straight to radiofrequency denervation. But insurance companies really are not allowing that. In Virginia, where I am, we actually have to do 2 nerve blocks for most of the carriers now before we're allowed to do the denervation.
Most of the places do 2 blocks, but somewhere insurances actually would require only 1 block, but this is not as common. Agreed.
Yeah, we used to do 1, and then ours was the opposite. Now we're, now insurance has switched to do 2. Mm-hmm. But like some of the CIS guidelines, recommend two blocks.
Mm-hmm. Next question, please explain the possibility of injuring the deep cervical artery especially at the C6-7 level, and if it would be safer to do all these techniques combined with ultrasound and X-ray.
Yeah, and they're going to talk, I think, about ultrasound at the next webinar. And so I think you'll be able to get more information in terms of kind of visualization of arteries and the potential side effects in terms of that at the next webinar.
Mm-hmm. Let me add that this C6-7 level is very challenging to do either on the X-ray or even with ultrasound. But with ultrasound, you can see much more. You'll be surprised how many variations and some kind of abnormalities or variants of anatomical variants you'll see with ultrasound. So if you don't use it, it's very important to use contrast and other techniques you mentioned, like digital geography.
Digital subtraction, yeah. And if you don't have, not everyone has that digital subtraction, so you could always try to use live.
Good. Next question, how often do you see post-RFA skin numbness, dizziness, and pain? How long does it last, and does addition of steroid to the RFA would impact the side effects?
So, a lot of people, I think, you do use that steroid to decrease that. In our practice, we almost never see it. We see much, much less than the reported numbers. Sorry. I was trying to go back to the screen.
One of the
that has the numbers. Sorry.
One of the ways to go ahead. Sorry.
No, go ahead.
One of the ways to decrease potential complications of this type is to adjust the temperature to the patient kind of the patient individual characteristics there. If you know somebody is hyperalgesic and they would not respond to 80 or 90 degree, you may consider going with a lower temperature, for example, 70. That may likely decrease the rate of this untoward side effects there. What do you think?
Yeah, and there was also, I've seen a study once about, use of diclofenac, just like 1 or 2 days of diclofenac preemptively after a denervation, that said was to decrease, the neuritis. Again, we don't employ that just because we just don't really, we don't see it fairly ever.
Agreed.
In our practice, yeah.
How many times can you repeat the RFA?
Again, I've never seen, I think this comes up a lot. You can't really repeat it generally, before 6 months in most cases. Again, there was, I talked about the Charcot joint where you don't tend to see that. It's hard if someone's really young and it's kind of like, are you going to do this every 6 months, a year, 2 years for the rest of their life? But generally, the patients who have gotten it repeated, a number of times tend to do fine. I've never seen like a cutoff number.
Okay, we have a few minutes for another few questions. You kind of answered this next question: inject or not to inject steroids in the end of the procedure.
And I guess another reason we tend to not do this, and I know a lot of people do, but we are just fairly conservative about steroids. So many patients with, say, pain, or they also have other conditions where they need steroids for. And so, to prophylactically do it, we just are cautious because we're kind of trying to save their steroid for other things, whether it be epidural or, a joint injection or whatever else they may need, that just not to add to their steroid burden.
Agreed. What about pacemaker as a contraindication?
Go
ahead, sorry.
Okay. We used to not do it, but there's definitely a thing now we will. Obviously in cervical, we definitely do it for lumbar. Cervical obviously is closer to the area, and so if you're going to do it, I would get cardiac clearance. I would have the device rep potentially there to turn off the pacemaker or to make sure that they're available.
If we can hear our sponsors' response, they would probably tell us that the technology get much better and the pacemakers are more and more protected. In our practice, we'll typically ask the electrophysiologist, cardiologist, and they would give us guidance on this.
Exactly. We do the same thing. Yeah, we definitely get that guidance before we do it in every case.
Good. Next question, any reason not to use ultrasound for needle placement? This would usually require posterior lateral needle tract. We'll discuss it in the next series. We're kind of close to the time when we have to conclude. Next question, how you absolutely ensure your lesion won't damage an aberrant loop in vertebral artery? That was another question. Yeah, it's we're kind of debating this, right?
I mean, absolute, I don't know if you can absolute ever really guarantee anything, but I mean, I think, you can try to use contrast to make sure at least your needle strip's not in that region. Despite the fact that I showed you that, I mean, I have, we've never experienced a complication like that in our practice. But, I'm sure there's, a specific way to absolutely ensure that you aren't damaging that using fluoroscopy.
There is a great comment down there. It's more kind of comment rather than question, so you all can see it. And I agree. It requires high level of skills to to do this type of treatment. Next question about Trident needles. And I don't have experience with those. Any?
Yeah, okay. We don't either. We use we use the Venom, but I have not actually used the Trident needles yet. There is another question about intra articular joint block. I know that there are guidelines coming on this type of procedures, and I think we'll get evidence-based answer to this. What do you think, Lynn? Yeah, so I mean, at least from the lumbar guidelines that came out, they did not find the intra-articular to be the case. But as Dr. Souza said, I think that was for lumbar. We'll have to see what happens with the cervical. But I agree that a small amount of contrast can really spread, and that's why I think if you're doing the medial branch blocks, using small amounts of local is key.
A lot of these questions are technical questions. We'll have to wrap it up, but there are nice questions about how to do it. I would invite you to get in touch through the American Interventional Headache Society for the details, and also there are upcoming workshops and seminars and boot camp, which is coming in the next month. Actually, it's going to be repeated, so you could get answers on all the detailed questions. Also, there are some thank you for excellent presentation. Of course, I agree. That's outstanding. One important question is about blood thinners.
Yeah, I wanted to answer that. So we follow the ASRA guidelines for that, and so it depends on what they're on, but we follow the ASRA guidelines in terms of making that decision making in terms of holding blood thinners or not.
Yeah, we always hold blood thinners for this type of procedures, but aspirin, NSAIDs, Cymbalta, for example, they can be continued there. Thank you all very much, and thank you, Lynn, for outstanding presentation, and thanks our sponsor. So we'll keep in touch with the next webinar. Thank you all again.
Thank you.